Good. Okay, so we're at 1:30. Hopefully, colleagues are gathered in the room and have got access to papers. I was saying to Hein at the lift earlier that I've lost access to admin control for some reason. That is probably my own technical fault, but I don't have any access to the formal papers, but I do have paper copies of them, hopefully up to date. But if I misstep because of not having the quite up to date bit of paper, then do let me know as chair, and I'll happily adjust myself. So do we any apology for the meeting? I think I had a list from Sarah that let me know that we had 5 or 6. I think Hilary Byrne, I think their medical committee colleagues couldn't make the meeting either, and we've got quite apologies from James Foster, Jason Stokes, Tony Dean, Trish Dorsey and James Granger. Are there any other apologies? Sorry, who was first? Michael.
Hi, just a quick one from me. I just not an apology, but I need to disappear between 2:30 and 3. So I don't know if you could weave my paper around those times. That would be very helpful for me. Thank you.
Yes, certainly, absolutely, Michael. I'm very happy to do that if colleagues are comfortable with that. So we'll make sure we rejig that around. Thank you. Just looking, which number is your paper?
It's usually 14, I think, traditionally, but let me just see.
It is, yeah, that's right.
Yeah, okay.
So I'd be happy to take that first if you like.
Okay.
James.
Yeah, James, just so I am assured that I've got the right papers in front of me, is your name under apologies on the agenda?
It shouldn't be, no. So you should have the part 1 papers without any names under the agenda as apologies.
Oh, right.
It has got my name under the chair's introduction though, and chair's action, so you might be looking at the right ones. But
and then under apologies number 2, it's got your name, but
it does have my name. Beg your pardon. Yeah. Yes, although I'm clearly here, although I do apologise.
Thank you. Just so I've got the right papers. Thank you.
I've got the right papers. Yeah, it's a good point, James. Thank you. Apologies for putting that name in error on there. Okay. All right. Thank you. So we'll move on then to, are there any declarations of interest that members of the committee would want to make known to the committee now that aren't in the general conflicts? And Sadie, is there any particular advice you need to give us about any conflicts during the meeting in terms of the items today?
Not as far as I'm aware, James.
Okay, great. All right, we'll take that as done then. Thank you. And then review of the minutes and the action logs from last time. Happy to go through the minutes in detail with colleagues. So they start on page 6 of 96, I believe. So can we just whip through those just for any matters of accuracy that people want to raise? So on page 6 and on page 7, on page 8 and 9, 10, 11, 12 and 13. So having no matters raised, I'll take those as an accurate record of the meeting and we'll get those signed. Thank you very much. And then in terms of the next item is the action log. And might ask for any help from Sadie here about items that we need to pick up.
Thank you, James. We're proposing that actions 122, 131, 132, 134, 135 and 136 are closed. And we've included the narrative for those. Apologies for the first one, 122, still being marked down, but we're proposing to close that today. the ones that remain open, 137, we have done some work on that in contacting and meeting with all of the risk owners, but obviously the risk register is on the next month's agenda, so the action will be concluded then. And the same for 138. Mark and I have discussed the risk tolerance around general practice resilience. We're also mindful of the wider work going on about risk management through the ICB. So hopefully we will have had that meeting by the time we next meet. Prescribing report action there for Michael. I might leave Michael to update on 139, which was around how to reach out to patient groups following the discussion last time. Thank you.
I think that was an offer to reach out to patient groups if that was people would find that useful. I don't know if I can. Who would I go through to offer that if we want to talk about it? It was shortages, really, wasn't it? And how they're handled in primary care. So I'm open to suggestions of where to go. I think was my suggestion, perhaps, rather than sort of seek it out. Yes, okay. So I'm happy to be pointed in any direction and offer to talk to patient groups.
Thank you. Sadie, do you want to come back?
Yeah, thank you. I think we can make the offer to practices for their
Okay.
patient participation groups. That would be really good.
Yep.
And probably a conversation with the locality leads around any avenues that they may have more locally. But otherwise, it might also be worth formally writing to Healthwatch and asking if there's anything that we can link into through our two Healthwatch organisations. Thank you.
Thank you, Sadie, and thank you, Michael. Okay, so we'll take the action log as done. I'll just take us through the other technical items, and I'll come to your paper, Michael. So, terms of reference, Sadie.
Yeah, so this is the first meeting under these new terms of reference that were approved by the ICB board. So really it's just to formally note that these are now the final set of terms of reference, and these will be the ones that we're working to as we conduct our business today and going forwards. I didn't have anything further to add to that, James. It was just for noting.
Great, thank you very much. That's very helpful. And then the forward planner, Sadie.
Just scrolling through as quickly as I can. Be with you in a second, sorry. Yes, so today's forward planner, you'll see that we're starting to populate further spotlight items on the forward planner in relation to some of the dental services that we are now responsible for now that formal delegation has taken place. In addition, we have postponed one item, which was around workforce and training, which was due to be heard today. I think we did have to be very careful with the agenda today because we had to rearrange the date and had slightly less time available to us with a lot on the agenda. And so that has been relisted for the May meeting instead, as you can see. Otherwise, no other significant changes, but as mentioned before, we will continue to refine this with you, and as we begin to stand up the dental and the general practice delivery groups, then business will be apportioned across those different groups so that we can get the right business to the right place.
Thank you. Okay, any comments or questions about the forward plan? If not, thank you very much, Sadie. So I think we'll switch now to item 14, which is the prescribing report. So hopefully, if you've got a good PDF manager, you'll be able to jump straight to that. And over to you, Mike.
Okay, thanks, James, and thanks for bumping up. Apologies, I have to nip out. those times. So just my usual brief report on costs, relative costs, some quality indicators around dependence-forming medicines and antibiotics, and some benchmarking data. So a couple of things to pick out. There's a couple of bits of sort of good news. I know spends are quite high at the moment for various reasons, but our relative spend across the east of England, we were second highest. We have dropped down to third highest in terms of net ingredient cost per extra PU, which tends to imply that we're doing something right in terms of cost effectiveness compared to our colleagues, and having the highest deprivation scores. That is good. Just on the cost pressures, so NCSO, no cheaper stock obtainable. This is when various, usually generics, become difficult to obtain. The price concessions go up so that it can be bought in from the global market at a more at a higher price. The projected spends for February have turned into actuals of slightly less than 557,000 pounds. The projected for March has actually dropped a little bit from 613 to 532. So slight good news there. But that's compared to December, which we had £1 million cost pressure due to a lot of medicines being in short supply, particularly antibiotics, due to the strep A incident that was occurring. So the other bit of good news is in hypnotics and anxiolytics, we were the third highest prescribers in the country for quite some time. We've now actually dropped to sixth, which is good news. And that will continue to drop relative to the rest of the country. And just looking at antibiotic prescribing, clearly over the winter months, antibiotics went up due to what I've just alluded to, the strep A incident, and patients were asking for antibiotics and being given antibiotics at a low threshold for sore throats, justifiably. So those indicators have gone up a little bit, although broad spectrum antibiotics, which is the ones we should restrict the usage of because it increases the risk of resistance over time, are at acceptable levels. There's only a few practices above what we used to call, above 14%, which was our threshold. There's only 4 there, but we've listed all the ones above 10%, which is the actual national target. We've just launched the prescribing quality scheme, and both antibiotic audits around adherence to formulary, etc., and the use of broad spectrum antibiotics are in that. So we're incentivizing and encouraging practices to perform those audits and have conversations with members of the practice who may or may not be adhering to what we regard as the local formulary and national formulary, etc. So all of that work is just sort of happening on its yearly cycle again. So that's all I had to note. Any comments, questions? I'm happy to take.
Thank you, Michael. I think we've got Karen with her hand up.
Thank you, James, and thank you, Michael, as always, for your paper. I guess the question from me is, are we going to do something a little bit more targeted in the 10 practices that are showing high prescribing? It's just that I do have the correlation with elevated incidence of C. diff. I know in the east of England we are an outlier for Clostridium difficile, and we're doing some very targeted work within Norfolk and Waveney to try and reduce those rates. I just wondered what the plan was for those 10 that are particularly high.
We part of the process, we will be talking to them about offering support to get those done early, particularly given my antibiotic lead, Jessica, is well aware of those practices, so she will be on the case to encourage and support practices to do that work. We do have a clinical pharmacist who will go in and support that work as well. So, there's no reason, what possible reason, could we for not getting it done as early as possible because of that very issue you talk about. Yeah, so we're on that. I can assure you.
Thank you, Michael. Did you want to come back on that, Karen, at all?
Try and get off mute. No, thank you. That's really good, because I know the infection prevention control team are doing some great work with Jessica. Thank you.
Right, thank you, and thanks, Michael. Hi.
Yeah, thanks, Michael. You talked about the table with the broad spectrum antibiotics. Now last time there were only 3 or 4 practices I recall. Now there's 24. So is there a driver for that?
Well,
big change?
so as I alluded to, we last time we just listed those above 14%, and
Okay.
there's 4 of those, but we've listed everybody above 10%, which is technically the national target. Not always easy to achieve, depending on, because it's 10% of how much you prescribe. And if you are a low prescriber of antibiotics for whatever reason, rightly or wrongly, then it is harder for you to achieve those relative percentages, because you'll be using broad spectrum antibiotics appropriately, we would hope. So we've just broadened the net a little bit, so we can show everybody who is technically above the target, rather than those we're most concerned about on this occasion.
Okay. Thanks.
Right, thank you. Any other comments or questions, colleagues? Otherwise, we'll take that report as accepted. Michael, thank you very much for that, and thanks for helping us rejig the agenda so that we included it. Okay, back to our agenda then. I think we're going back to service development, and we are starting with the learning disability health checks, I think. And that starts with yourself, Shepherd, on learning disabilities. Over to you.
Thank you, James. Where do I start? Okay, fantastic. So you don't have a paper from me this month. I was planning to bring the paper next month, a more detailed paper with our end of year position. So we'll update the planner to reflect that. But I'm really in a good mood today because our numbers are looking good. And I want to use this moment really to appreciate the hard work that has gone into the learning disabilities annual health checks, and also to just celebrate the progress that we have made this year. So with that, I'm going to confirm the numbers where we stand, and also just give some observations and comments on our areas of our strengths this year, and also areas where we need to probably focus a bit more for this coming year. So starting with the 5 localities, 3 of the 5 localities have managed to complete over 75% of their annual health checks, which is really a big achievement. And 2 localities have done well but did not get to meet the 75% national minimum target. So great. North Norfolk is leading in our system. They managed to carry out about 85%, followed by Great Yarmouth and Waveney, 77%. Then followed by South Norfolk, again 77%, with West Norfolk at 72%. Norwich, it came as a surprise. We are looking at what happened in Norwich because they did so well last year, and the numbers are really a bit low at 64%, if you want to round that to that. So we've got an overall achievement of actually 75% on the dot. So which is a great achievement compared to any other parts of our region, and also looking at last year and previous year's performance. So we have seen approximately 1,000 more people compared to last year. And to be able to get to that, you can only imagine how much has gone into this in terms of resources, in terms of time. So our practices have been busy. And to be able to get to this point, I think, like I said, I really want to appreciate, first of all, this committee for actually paying a lot of attention on this important matter, because we've been doing this month on month, and the support and the challenges come from here. and also our quality team that have spent a lot of time talking to practices, going through the individual cases to support to actually reach to every family that we were able to reach this time. And practices have prioritized this. They faced lots of challenges to be able to do this. And our own internal organization around the improvement of data, we've got an amazing data system, the Power BI that we have, which helps us to track month on month what we have done and where we are. So whilst we've achieved the national target, that is not where we want to end. And I just want to put the absolute commitment that next year will be even better than this. And in the region, we are leading in terms of improvement, in terms of the number of people that we've seen, and that commitment is there going. So that is in terms of highlights. And I think it's fair to say we have now established even more stronger connections with other parts of the system, not just in Norfolk, but beyond Norfolk. We're looking at SNE, we're looking at Essex, we're looking at Hertfordshire to really maximize what we can do for these population groups. And internally, we've got stronger connections with each locality and with practices, and the conversations are happening. Our delivery groups are meeting as every other week to really focus not only just on the uptake, but on quality. So this coming year, you should expect, or you should feel more of the qualitative stuff, which is attached to those numbers. So I look forward to that. Then in terms of the challenges, just to signal some of the challenges that we face as a system, I think to get to this, I think it's fair to say the system, there are tensions within the systems in terms of priorities. And to keep this agenda at the top of all other priorities, it's hard work and it takes a lot of energy and strength. And also there are different organizational focus and priorities. And those also present a challenge to be able to really transform the care and treatment of this population group. And also the other good but still needs further improvements is around our use of data, that is data coding stuff. Whilst our performance for this end of year say 75%, but actually we believe that we have delivered more than that. There are some practices that have confirmed that the numbers on the system are not reflective of what they've done, with more than 50% of activity not recorded. So potentially, once the validation process has gone through, our figures may improve beyond 75%, which is good. Then there are other principles that sit in our system that actually don't work for this population. So for example, principles around equal distribution of resources does not support this agenda because this agenda has never been equal before. So to try and apply that principle as we go forward, it's not addressing inequalities, because for a long time, this population group, we have not invested enough in that. We've got other pieces of work we need to do around improving the quality of health checks to bring that consistency. But we start from a position of trust and a position of appreciating our clinical teams, but we've got some work to do as a system to build that. The final observation I'm going to make is around most of these challenges are inherent to the challenges that we have around practice resilience. So for example, the areas that have not done well, a good number of those practices are on our practice at risk, which means that they need additional or a different approach to be able to support them, to be able to prioritize this group of people. So those are kind of insights into what would probably show in our end of year position, but a massive kind of big congratulations to our system for getting to this point, and also to the leadership support, because I think without that support, we would not be able to drive this agenda forward.
Thank you. Thanks, Shepherd, for that. And it's very welcome to see the focus on equalities there as part of that item, and helpful to pick out the areas which need particular attention geographically in terms of place, I mean, as well as the overall acknowledgement of the progress that the system has made. I know with my professional hat on, Director of Adult Social Services, this is an area where actually there are wider, broader challenges in the health and social care and housing systems for people with learning disabilities and indeed autism as well. So it's very welcome to get that progress update. Are there any questions or comments from the committee about that? James?
Yes, thank you very much indeed. And just so I can reclaim a little bit of credibility, my comment about you being in the apologies, I can now see that you have a name against each of the items, and obviously it was you to lead on that item rather than saying that you were an apology. So just, as I say, just to get a bit of credibility back. And then secondly, Shepherd, that's really obviously great news, and thank you very much for everybody who is helping to look after our population. I've never ever heard, I don't think, an officer said that we've got a great IT system. So that is really quite rewarding to hear that somebody is praising the system that we have. So thank you very much indeed. And obviously, because where I sit, and we have the 2 ICBs, etc., I'd be very interested to see what the figures are in SNE, just so that, because I sit up here in Lowestoft, I can champion that Great Yarmouth and Waveney are doing a great job in this. So thank you.
Thanks, James. I'm sure we can get the figures breakdown to you via Shepherd for that. Karen?
Thank you, James. It's a comment really just to say thank you to Shepherd. You've got a driving passion to improve, and that's just been evidenced. I haven't been to the committee for some time, and to hear that you've got to 75% is such a wonderful achievement, and I know how hard that's been. So thank you. And it's all about improving the health outcomes for our most vulnerable, isn't it? So thank you again.
Indeed, thank you. Karen, Sadie?
Yeah, thank you, Karen, for that. That's lovely of you to say. I think it is fair to say that we are delighted with the progress that has been made in this area. It's been one where we've been rightly under scrutiny for several years, and I'm really pleased with the progress that's been made, despite the fact that we still want to go further. I would also just like to mention to committee that I saw another email today from one of Shepherd's team, and it isn't quite as good, but it's still very pleasing nonetheless that the national target for health checks for people with severe mental illness is 60%, so significantly lower. And we haven't quite hit the target. We're at about 52%, I think, final year figures, and that will be reported in more detail at the next committee. But again, it is the best uptake that we have ever achieved as a system, and there's been a big focus on it again this year. Shepherd's been working on learning disability health checks for a couple of years, whereas this one hasn't been going with the same level of focus for quite so long. So again, a long way to go, but pleasing progress to date, and expecting much more next year.
Thank you, Sadie. That's very helpful to know. And yeah, just add our all of our thanks, Shepherd, for the work of the team. I'm sure there's a broader group of people that you could give feedback to on behalf of the committee and the committee's appreciation. Thank you. Great. Okay. With the committee's permission, then we'll move on to the next item. And this is the Norfolk and Waveney ICS quality strategy. And I think, Karen, you're here for Tricia today, aren't you? And you're going to us through this.
I am indeed. Thank you, James. So in the terms of time, I'm going to assume that everybody's had the opportunity to read the quality strategy. So I'm not going to do a page by page turn. But I'm really pleased to bring to this committee our quality strategy for 2022. We've been working on this for some considerable time to 25. And I really have to personally thank Evelyn Kelly for the phenomenal work that she's done around this in pulling together our system partners. So really, I brought it to Primary Care Committee today for people to note the contents and to also formalise the primary care links to support the development of the implementation of the plan. We can have the best strategy in the world, but it's not a paper document. It's about what we do with it and how we implement it and how we work collectively to get the very best of it. So the strategy sets out very much the strategic direction in how we develop as a system. And that's very much through a culture of compassionate leadership and really focusing on improving the care and quality outcomes, ensuring the services that we all provide are safe, sustainable for now and in the future generations. And that's particularly key at the moment in the current position we find ourselves in as Norfolk and Waveney. It's about using those insights around health inequalities and population to make sure we have fair outcomes for people in Norfolk and Waveney, and particularly that we support the values of integration, which is why we're all here today, personalisation and outcome-based commissioning, and that we develop our local team services and communities to really promote the well-being and prevent adverse health outcomes. I think we have to really move away as we progress and develop and mature as a system into prevention rather than illness. So we had some excellent engagement from one of our primary care GPs and one of our advanced nurse practitioners in supporting the primary care focus. So in terms of next steps, this has been ratified through the ICB board. And at the moment, it's with our comms and engagement team. We're looking on the pre-publication design work. We want to make this as visual as possible and as readable as possible for all. So we have got an implementation plan, which we've met as a system to make sure that people are joined up. And we will make sure that we have a governance process wrapped around it. More importantly for us, it's about making sure we're listening to our public, patients and carers and making sure they're central into the delivery and evaluation of our strategy. So on the paper, you can see there is an implementation timeline. I can tell you that we're on track. And at the moment, we're developing the implementation plan with a number of metrics which are really outcome focused. And we would very much like the committee to one, oversee the implementation of the strategy, but to help us develop the metrics that particularly relate to primary care. Because as we progress into place, I think it's really important that there's a voice there. And obviously, we will include the local representatives at the committee to make sure that they're absolutely part of that. I'm very happy to take any questions. It is a comprehensive document. And I'll stop there, James.
Thanks very much, Karen. And so I'll broaden that out. I might nudge any other officers of the ICB want to make any kind of contribution from their perspective on this before I open it to the committee more generally. It's certainly, I know as a board member, but also a chair of other groups, it's been well engaged across the whole system, hasn't it, really? So this is our opportunity here to think about how we as a committee will use this in our work going forwards. Mark.
Thanks, James, and thanks, Karen. And I know we've talked about this before, and I think this is really, really important for us, just to state the really obvious. But it's about embedding it now, communicating and embedding it, isn't it? So just to kind of highlight absolutely around primary and community care, general practice, and more broadly. But I think the inequalities and prevention angles are the ones that I'd like us to be particularly focused on in the coming weeks and months. I know we've got real challenges as a system, haven't we? But actually, if we forget that element of it, then we are going to struggle. And it links absolutely, doesn't it, James, with the work we do with council colleagues and the like. So that's why I just ask that we check back in weeks and months to come and years to come that we're really focusing on those areas, please, Karen. But yes, very supportive. Thank you.
Thank you, Mark. We've got Tracy absolutely plugged in. Thank you.
Thank you, Mark. And Karen, you've placed some emphasis, haven't you, both in the document and also what you said to us about the role of the place-based programme boards and the place-based health and wellbeing partnership meetings. And I know that members of the committee will interface with those individually at place level, but there's also an element of which we as a committee need to understand how that place agenda is going to develop along the lines described here, really. I don't know, have we as a committee had a paper to discuss place or had a discussion about place? I'm not sure we have. I don't want to create more work for our committee because clearly there's a patient and communities committee that also focuses on this area, but I wonder whether that might help us in some of our thinking going forwards. Mark, that's triggered your hand.
Yeah, absolutely. I don't think we have. I don't believe we have, unless someone corrects me and I've missed a meeting that we have. So I think that would be a good idea. I think there's lots of discussion still around place and its role in the future and the form and function. But perhaps in the next few meetings, it would be good to have something brought here, James, if that would be helpful.
And I think it would be helpful for this committee to get a really strong view from primary care about how it feels that it can engage at place level on issues like quality and inequalities and so on. So that would be useful to do. Okay, any other comments or questions from committee members? Otherwise, Andrew.
Yeah, thanks. Yeah, thanks, Karen. I think it's a really detailed paper and enjoyed reading it. Can I just offer from a Healthwatch point of view to do with the communications, in that without wishing to cast any aspersions, we've noticed that some of the communications have not always been brilliantly accessible to patients and the public. And although the paper is very detailed, it's also kind of management speak very heavy as well. And I wonder if we could help perhaps with a bit of the translation and making it more patient and carer and public friendly. So that's just an offer, really.
Thanks, Andrew. That's a really good offer, which we'll accept. So we'll be in contact with you. That's great. Thank you.
Thanks, Andrew. Mark? Is that a legacy hand?
Sorry, it's a legacy one, James. I do apologise.
That's all right, no worries. On that communication point, I had the benefit of going to one of the national NHS meetings this week for the launch of, I'll probably get the title wrong now, but it was NHS Impact, I think, and a new sort of infographic about quality and improvement. And it was very, very powerful stuff. There's something about aligning our comms with the NHS England comms on this agenda, because it's being strongly pushed, isn't it, for all of us to try and make a difference to outcomes. So I was very cheered by that. Okay, so I think committee are asked to receive and respond, which we've done, and to consider how we can support and oversee implementation. Also, I think we've done actually made a couple of suggestions to you, Karen, for that. So I think we will agree those two recommendations. Thank you.
Thank you, James.
Thanks a lot. Moving us on then to appointment of dental attendee to the committee. So I recall we had some email exchanges about this, about attendance and observation. Am I handing over to Fiona for this?
Mm-hmm.
Fiona.
Yes, thank you. So committee members will be aware that within the revised terms of reference, and as a result of the delegation of pharmacy, optometry and dental services to the ICB from the beginning of this month, that we have asked for representation from the local representative committees, but we also would like to appoint an individual who represents the dental services to this committee, and it would be somebody who may be a dentist or from the wider dental care dental team as a dental care professional, or even potentially a senior practice manager or similar. So this paper just sets out the role, the process for appointing that individual, and we're asking committee to agree to the process, and then we can start to recruit someone.
Thank you. Very clear. Any comments or questions on this? I mean, at one level, this is very straightforward, Fiona, isn't it, for us to just agree? So are you wanting us to discuss, or for form's sake, really, rather to agree? Sorry to be a bit procedural about it, but is the committee in agreement then? Hein?
It all looks fine, James, but I just want to pick on a comment Fiona made that it's a dental representative, and in common with other committees, I don't think it's a representative, but it's somebody who brings dental experience and expertise to the benefit of the wider proceedings. So I think that for the minutes, I think it's important to distinguish that. That's all. Thanks.
Thank you. Yeah, that's very helpful. Okay, so I think, Fiona, we've therefore noted the report and agreed the process for the appointment of the representative to the committee in line with what you've described, and in the terms that Hein has clarified as well. So thank you very much for that. And so the next item is item 10, which is NHS transition. And again, it's back to you, Fiona, isn't it, for us to talk about the broader picture of how these services are transitioning to us.
Yes, so we agreed that we would bring a paper setting out exactly our responsibilities and the key challenges that we will be managing from this time forward for pharmacy, optometry and dental services. I will take the paper as read, but I think it's worth highlighting some of the challenges. I think the one common theme for all primary care workforce, and not just primary care, of course, but across the whole of healthcare, health and social care. But the common theme is workforce recruitment and retention, and the challenges that we have in attracting and retaining people in Norfolk and Waveney. There will be a report coming to the committee in May from the primary care workforce team. So I've not gone into detail in my paper for that reason. I wanted to also to highlight that we are working very closely with each of the professions, and we want to work with them to find the solutions. There are no easy answers for solving some of these challenges, but in working together with the professions and also listening to our patients and helping to understand their concerns, hopefully we can find the right solutions. In terms of community pharmacy, this is actually, I suppose, moving forward largely to the because of the regional partnership community pharmacy strategy that was agreed a few months ago. And obviously our focus will be on mobilising that and looking at where else we might need to support community pharmacy. For dental, without a doubt, there are huge challenges here. The access for patients is extremely poor. And we are very keen to support the dental profession. So what we've agreed and what we've said is that we will agree a year one plan by September of this year, and that really sets out those sort of short-term initiatives that we're working on, and then to agree the dental strategy by March 24. However, I think it's been very clear from some of the early conversations we've been having with the dental profession, that there may be some more urgent pieces of work that we might want to do to address some of the critical problems around dental access. And we'll be talking about those at later meetings. And also around dentistry, I just wanted to highlight that we have created and established the Dental Development Group, and that's part of our engagement with the profession. And there are representatives from across the dental profession and also Health Watch and across the ICB, and hopefully that they can also work with us to help find solutions and look at the workforce challenges as well. Discussions through that group will help to inform the development of the Year 1 plan and the strategy, which obviously will come to this committee for approval, and any business cases in the interim will also come to this committee for approval. But I'll stop there, and if you have any questions.
Thank you very much, Fiona. So the discussion in May on workforce will be very welcome, and note in this document in the paper itself about the future plans around strategies being agreed and the timescales for those. And I'm sure the committee would want to also express its concern, as you have really, about the accessibility issues, particularly for dentistry. I mean, it's very stark to have a paper that says, you know, nobody is open for patients at the moment, as the paper indicates. So it's a very difficult situation for patients in Norfolk and Waveney in that particular regard. Are there any comments or questions from committee members about what Fiona has outlined? James.
Yes, thank you very much. And I think this is absolutely hugely crucial, as we all know. But reading the paper where it says there's approximately 13,000 appointments that were missed during the period July-December, I mean, this is outrageous, isn't it? I mean, those appointments you'll never get them back. You just cannot, that time's gone and you can't do them. So that's my one point. Are we also within the new strategy able to reinstate, if I can put it that way, where providers are indicating that they're not going to be able to fulfill their whole UDA number for the year, that they will be redistributed to other practices that can, so that we do not lose the UDAs? Is that going to be within our gift? Thank you.
So to answer your first question, I think the concerns around missed appointments, obviously this is not unique to dentistry, and it's certainly something we'll be working with our comms and engagement team around. It's about the value of healthcare services, and so there's a big piece of work to do around that. In terms of UDA activity, obviously we want to work very closely with our practices, and there has been a recent change in the dental contract, which would allow us from next year to renegotiate contracts. But up until that point, it is with agreement with the practices. But I think what's more important for us is actually to understand the challenges and the reasons why our providers are struggling to achieve their activity, and trying to resolve those with them, so that actually the providers that we have and who we value value, that we work with them to understand the pressures. And obviously one of those we know will be workforce pressures, and we need to understand what we can do to support that.
Thanks, Fiona. Sadie?
I just wanted to add, and James will probably be more aware of this than I am, but there is an end of year review process which results in underperformance, if you like, of activity under a certain level, meaning that monies are returned to the commissioner, and we will have an end of year process coming up shortly, and we will of course keep committee up to date on what all of that looks like. We're still on day 21 of having received the delegation of these services, working through some of the detail on this. But I think it's also important to note that dental services have been delegated to us under a ring-fenced budget. So our funding is ring-fenced for dental commissioning, and I know we are yet to agree all of our budgets with NHS England as an ICB, but I think that sort of is quite a strong indication of how we're expected to use the funding with the delegation responsibility going forwards.
Thank you, Sadie. Fiona, in the report, you've clearly identified the need for the ICB to be in listening mode, both to the professions and to patients. I just wanted to clarify, were you expecting this committee to engage in any kind of engagement activity outside of what the ICB is doing in the sphere of commissioning and engagement and strategic work at all?
I think from our perspective, we want to use every opportunity and every forum that's available to us to understand the issues and concerns, and particularly, you know, around some of the patient groups that are affected, particularly, so we'd welcome if, you know, support from the committee. And I suppose highlighting and raising the profile and the fact that we are now responsible for these services. So how can we work together as a system to support these services, make sure they're resilient, and can offer safe care. It is every, you know, it is a I think is it impact when there is vulnerability in one part of the system, it does impact other parts of the system. So I think that, you know, we want to use every opportunity we have to raise that that profile and that voice.
Okay.
Thank you.
Yep, thank you. Any other comments or questions, committee? Otherwise, I think we're asked to note this report about the progress and obviously to schedule the future discussion points as outlined. So thank you, Fiona. We note therefore that report. Thanks. So that, I think, moves us on, doesn't it, to item 11, which is our CQC reports on particular surgeries and quality in general. So Shepherd, over to you. Thanks.
Thank you, James. We've got one published report since the last meeting we had, and it's for Matshaw and Lenwood practice. The inspection was carried out back last year in December, and we have now received the report. And just to say that this practice has already been added to our support register that is reported in part 2 of PCCC. So just for this meeting is just to highlight the key areas that have been identified. So out of the 5 CQC domains, 3 domains have been rated as inadequate. And those are to do with leadership, safe services, and effectiveness. The other 2 domains, that is caring and responsiveness, have been rated as they remain rated as good. Just to assure you that intensive support is now in place, and we are meeting with the practice and CQC and members of the multidisciplinary team from quality, medicines management, and all the key team members to support this practice. And the meetings have been going well. There are no immediate concerns in terms of patient care or patient treatment that we are worried about at the moment. More discussion will take place in in part 2. But the key areas, obviously, they remain the same. I think we've highlighted this before. Leadership is work that we're doing with CQC through the training bite size, and that is being led by CQC. Michael is leading on medicines management, which is another feature like other practice. Then the issues around governance is another continuous challenge that we are facing, that we are working with practices to strengthen their monitoring and effectiveness of their systems and structures. I will stop there, but I know that we're going to have more discussions in part 2.
Thank you, Shepard. Any questions to Shepard on this particular item? As I say, there's an opportunity for a further discussion as well. Andrew.
Yeah, thank you. I think I may have asked this on a previous occasion, but as you're probably aware to the public, this term inadequate is upsetting and worrying, and I wonder what steps do we put in place for communicating A, with the public as reassurance in a sense, but B, exactly what that means, because it's not a clinical judgment, it's more of a really a managerial judgment. So it does not mean that the individual doctor or nurse or clinician they see is in any way unsafe. And unfortunately, that isn't always communicated very well by the CQC. And I'm afraid it has parallels with, I'm sure a lot of you have heard recently about the Ofsted reports where the head teacher committed suicide. Now, I'm not saying that that's likely to happen, I hope, with this, but there are, I think there's a great misunderstanding of what the CQC does and what the judgments mean. And maybe it's incumbent on us to communicate that better, both to support the public and to support the staff, of course.
Yes, thank you, Andrew. It's not very well understood, is it, the role of clinical regulation and quality regulation and the differences between CQC and the other work of other regulators and professional bodies. I'm sure we could do more to communicate actually what the differences are and how the public can be reassured, but also to create expectations for movement from inadequate to back to at least good. Karen, did you want to comment?
Yeah, thank you, James and Andrew, for your comments, and for Shepard really in terms of the report he's just provided. I guess for me, from a quality and safety perspective, the CQC are there to sort of, in terms of the patient safety. I know that Shepard hasn't elaborated onto the amount of support that we give the practice internally from the ICB, from my team. So it really is matrix working and making sure that everybody is supported, as in with any particular incident. If anybody is particularly adversely affected, then we make sure that people are referred for the right level of support, and we have trained practitioners that can visit if there has been an adverse incident identified. I guess for us it is about the standards, and we need to make sure that although the CQC, how it's expressed, may be challenging, it's understanding and it gives the public some reassurance that things like meds management and their care is being managed appropriately. But it's getting the balance right. I do hear what you say, Andrew, but it's also a level of assurance to the public that the CQC have visited. But I think it should be the positive message about the support we're giving those individual areas. Thank you.
Thanks very much. That's very helpful, Karen. James?
Yes, thank you very much indeed, and thank you for the report. Could I just ask, because Shepard, you do say obviously that once this report has come through, it comes onto a register, and I do accept that we're in part 1 of this meeting and not part 2, so I accept that. What mechanism do you have to put surgeries onto the register prior to a CQC, so that in other words, we have a system so that the CQC is not a surprise? Because I imagine on a number of cases, they're not surprises. So at what point do they come on the register and you are giving them the support?
Shepard, sure.
Yeah, thank you for that. The register is inclusive. It also includes those that are not on CQC inadequate rating. So we've got practices that requires improvements. At some point, we had practices that were good, but we thought the situation may change, especially to do with it. We've got a key that we follow through to identify practice, and we are strengthening that because I think there are some practices that have been rated as outstanding that maybe now they are no longer outstanding because of the time that those inspections were done. So we are working quite closely with the matrix and also with CQC to try and share intelligence to support practice at an earliest opportunity.
Could I just come back on that, James? So I absolutely take that, and I'm sure that's the case, and please do not think I'm being critical. But as you said that this is now onto the register, when you've gone from good and then get 3 inadequate and being inadequate and 2 not being actually inspected, could I have expected it would have been on the register before?
That's a good question. I think I would suggest that I wanted to have more discussions in part 2 about this rather than.
Yep, certainly. Thank you.
Thanks, James, for the questions, though. Karen.
Thanks. Just to come back in, we do an enormous amount of training with our primary care colleagues with Shepherd's team, and we do something called bite-sized training, where we invite a number of our practices, whether that's practice managers, the multidisciplinary team, and the CQC also attend, because actually sometimes it's about not getting the right evidence on the day available to be able to meet those standards. So sometimes that's tragic when things fall down, because it is a moment of time that you assess. So it is important just to recognise that the CQC do work with us, with our practices, to support, that level of good achievement. Thank you.
Thanks, Karen. And Sadie?
Thank you. I mean, if we look at 2022 as a year, we had 9 inspections in 2022, 3 of which were rated good, 3 were requires improvement, 3 were inadequate. The way that inspections are carried out has changed quite significantly over the last few years, and some of our practices haven't been inspected since 2015. We are trying to shift the focus towards a much more proactive way of supporting practices and spotting things that might need extra support early. But as my colleagues have said, it is very resource intensive supporting practices that have already been inspected, which means that there's less time available to support the bits that we'd like to be doing more of. But Shepherd's team is working on and we're intending to implement it this year. It has faltered a couple of times due to pandemic related stuff, but we plan to implement a practice visit programme which will enable us to be really supportive to practices and to spot issues of resilience or process, and then put the right support and training in, which will benefit more than just that individual practice, because we'll make it available to everybody. And again, for this committee, there is an annual process through the GP contract, which is called an e-declaration. And that happens, I think it's in the autumn for our area. And the team is currently working on pulling together a summary report of the declarations for all of our practices. And again, we need to get a better process in place so that all of this information is contributing to us triangulating where we might need to help practices before a demoralising CQC inspection. Thank you.
Thanks, Sadie. Really, really helpful explanation. Well, committee, I think we've done that justice, actually, not only on the individual practice, but on the general issues there raised by the CQC process. So it doesn't say Shepherd, but I presume the recommendation for the committee is to note that report. And so we've noted that, and we'll move on to the next item. Thank you. Which is back to you, Shepherd, for an update on the GP contract, I think. Is that right?
That is correct. And just to say, this is for Notting too.
Thank you.
So I will take the paper as read and obviously take some reactions or comments, but just to highlight the key changes from the contract for 23-24. It's in relation to access into general practice with some adjustments on the funding to support that ambition of improving access, and also adjustments of flexibility around workforce, which is more to do with the as roles, the additional roles, than on immunization and vaccinations. And I guess it's, I think one thing to highlight is that drive to improve patient experience and satisfaction, being able to access services when they want, which is most welcome in terms of addressing health inequalities. But I want to stop by just acknowledging the fact that access to primary care, more people have managed to access general practice, and our data shows that, but we still have to improve to address some of those health inequalities. There's a piece of work that I'm leading and supporting the system to do, that is on access improvement plans, which we will report in future when that is when that has progressed. I will stop there because I think the detail is in the paper. It's a high level.
Thanks very much, Shepherd. And should we start by saying, actually, we did get some comments as well, I think, from Naomi in relation to this item. And now I've been a bit remiss, actually, because I also had some comments for agenda item 8, which perhaps we will append in the minutes, or note that we took them, that they've been considered actually by officers. But on this item, there were a couple of comments, and I don't know whether anyone wants to pick those up on behalf of Naomi. There was a particular question about what digital screening platforms meant in relation to the contract specifically. But do you want to say anything about the comments that we've received and how we might respond to them first, and then I'll bring Hein in. Thanks.
Thank you. So for this particular item, I think the first paragraph of Naomi's comments were really to set out the BMA's GP committee and their rejection of the contract and the reason why. And I think that is really important for us to note in this. The rest of her comments, as you say, are in about a bit of detail around digital access and screening platforms. And I think it would probably be helpful for us to take those away to the digital team and ask for clarification on those, and we can circulate the answers round. But the first part we'll certainly note in the minutes. Thank you.
Thank you, Sadie. Very helpful. Hein.
Thanks, James. Shepherd, the note refers to an upcoming review of ARRS, the Additional Roles Reimbursement Scheme. Could you say a bit more about it? Because hundreds of additional roles have been created over the last few years. So I think on one hand, very welcome. We've also seen some dynamics where the influx of clinical pharmacists have meant a drain on pharmacists elsewhere in the system. So would be good to hear a bit more what that review will entail and when we can expect as a committee to hear from that.
Excellent. Thank you. I was equally curious when I read the update. First of all, I want to acknowledge the fact that Norfolk and Waveney are leading on the ARS recruitment program, and we've got more people recruited through those roles. In terms of what this means, I have discussed with my colleagues within workforce, and I have been informed that this is a national piece of work and it's being led at that level. And there's a task and finish group that has met, and ICBs are included in those discussions. There are plans locally to set up our own task and finish group to actually work through what this means in terms of supporting the ambitions that we have for improving patient access, for improving patient experience as well. So that's how far I can go with this at the moment. I think there's still a lot to be worked through. In terms of when this will come, I think I would like to have further discussions with our colleagues to see when it is the right time and meaningful to bring it to this space.
Yeah, just a comment for you, James, as chair. I think we have the desire with the emergence of these delivery groups to make this committee more strategic. That this would very well fit within this more strategic discussion on whether you make the shifts in the workforce. So,
yeah, very much agree, Hein. That's a really good point. Okay. Okay, Shepard, anything else to add from your perspective on what you've heard? Otherwise, we'll go with your recommendation, which is to note the report.
Thank you. No.
Thank you for updating the committee. That takes us to the finance section, I think, of our agenda and to the finance report. So we've got, I think, a presentation. We've got Stephen with us. Who am I handing over to cover this item?
I think it should be James, should be giving us the update.
Okay.
James is not there today, so I'm covering his presentation today.
Thanks,
no problem. So I'm just going to I'm assuming that you all have read the report already, which was distributed, and but I'm going to highlight the key points in the finance section for you all. To begin with, the executive summary page has explained about the timing of the CCG and the month ends for the ICB. So the report which we have showed or presented is relating to February, which represents 8th month of the 9 months of the ICB accounts and 11 months of the financial year, with a forecast for the 9 months for the ICB. The main points or the highlight points are that the primary care and prescribing budgets are overspent by 2 million for the ICB, which represents Q2 to Q4 of this financial year. However, this does not include the 5.6 million payment due from NHS England for the additional hours spent. So when that is included, the actual position would be an underspend of 3.6 million. Now, moving on to the financial summary, we can see that the GP prescribing costs are showing an adverse variance of 6.3 million as against the plan in February. And this is a jump of 1.2 million from last month, i.e. January. The same drivers, which are the NCSO cost pressures, are the main reason for this overspend. Apart from this, we are also noticing that the pressures on the admin cost for prescribing or the dispensing fees, which sits in the delegated cost center, has increased, and it's increased by 0.5 million between the 2 months, January and February. However, because there is the additional hours spent, which is to be retrospectively claimed, hence this line is showing an underspend. Now, the detailed financial analysis shows the reason for the main overspend in prescribing. And as I have explained, it is the NCSO cost pressure, SGLT2 drugs, and the continuous glucose monitoring, which are the main drivers for the overspend. there is a high degree of uncertainty over the financial implication of these factors for the new finance year 23-24. We do get the EPAC data from the MEDS management team for the DOACs, the CGM, the SGLT2, and what we are witnessing is that there is a year-on-year increase, and the increase continued also in month 11, i.e. in February. Now, moving on to the delegated cost centers, the main reason for the underspend in the delegated is because the PMS GMS budgets are ring-fenced within the delegated primary care, but we are seeing additional cost pressures for the dispensing fees, which I have already discussed with you all. The GP prescribing slide also, again, it shows the same story, which is that the overspend is 6.3 million as against the plan, and it's 1.2 million as against previous month's FOT and this month's FOT. And the reasons are once again the same: NCSO cost pressures, the diabetic drug prescriptions going higher. Also, the NHS recharges for the flu vaccines were lower than expected, and the rent for Beckles House has increased. Apart from this, there is also an Appendix 1, which is being incorporated into the report, and this is looking at the financial position for 22-23 for the POD, the pharmacy, optometry, and dental services. Although the CCG has not yet been delegated the board budgets yet, but we are working very closely with NHS England to understand the financial risks that might transpire in 23-24. And as you can see that out of the three services, the underspend is mainly in dental and optometry, and that is mainly because of the reason of lack of access and lack of activity, while pharmacy is overspending. These trends are replicated at a regional level, and we will need to understand the granular drivers of these variances as they are delegated to us. I don't have anything else to update you all, but if you all have any questions, I'm more than happy to take.
Thank you, Rashmi. That was very, very clear. Thank you. Any questions from committee members then on the detail of that?
No question, James, but I echo your comments. Very clear. Thank you.
It was great slides, yeah. Anything you want to add, Stephen, on that in the background?
No, I think that was very clear from Rashmi. Thank you.
Yeah,
thank you.
Brilliant. Thank you very much. So that takes us, I think, does that take us to any other business now, having done the prescribing reports? Is there any other business? So committee, what time would you like to reconvene for part 2? Do you want to take 5 minutes and jump into part 2? Oh, have I missed? Actually, I've missed the questions from the public. I do apologise. Do we have any questions from the public, Sadie?
We had one submitted to us in writing, which I'm just trying to find. Here we are. And so we are responding outside of the meeting, and this will also be published on the website. Would you like me to read it out, or yeah?
Yes, please.
So the question was, what plan does the ICB have to develop a process to consider potential proposals / partnership opportunities with industry, potentially of mutual interest, and mechanism to engage with industry / pharmaceutical companies? The person who submitted the question said that they had some ideas, and one of them had just been accepted at Cambridge and Peterborough ICB, which they were happy to expand on. So our response to that is that we have a draft policy around sponsorship, which is currently progressing through internal governance routes in the ICB and will be published in June. In the meantime, we invite industry representatives to write to the ICB for the attention of our medicines management team with detailed information on their request or proposal. In considering a response, the medicines management team will have regard to the ICB's formulary and the cost effectiveness of the pharmaceutical company's request or proposal.
Thank you, Sadie. That's helpful and clear. Are there any other questions from members of the public in the meeting? If not, then I think we are closed as a committee meeting. Thanks, everybody. Shall we reconvene at 2 to 3? Is it okay to have a 5-minute break and then reconvene with a cup of tea at 14:55? Thanks very much.
Thank you, everybody. Thank you very much. Bye-bye.